So good afternoon, everybody. Thank you very much for joining this session. It's actually a particular session because I think it's the first one dedicated to eyes at EuroPCR, but I don't remember we have done one at London Valve, maybe in the future. So we are very happy to see you in this room, and it's late already in the afternoon, but happy that there is a lot of interest for that topic. So we will have a couple of talks first, and then we will show you cases. And the goal is also that you react to the presentation, that you ask your question at any time. You can stand up and go to the mic. You can ask it electronically. Nina will look at it during the session. So I have a wonderful panel with me. I have Nina Wunderlich from Germany, Felix Kreidel, Germany as well, and Stefan von Bardeleben. So it looks like Germany is a very early adopter in eyes technologies. And then we have a true expert from Italy as well on eyes. So different countries liking this technology. And the objective is to introduce a little bit. So we think that most of you do not have seen eyes or do not have a lot of experience with it. So we will try to introduce the technology, the indication, and then to show you some of the application of this. We would like to start with a poll asking you who has already used eyes and is already confident with this procedure. So maybe you can raise your hand or answer electronically, and we will show but maybe raise your hand. Who has done eyes procedure or is familiar with this for any kind of indication? Okay, so that's a little bit what we were expecting, a minority. You can answer also electronically, and we will show the result. So I just would like to give the word first to Nina, just to show the challenging of tricuspid imaging as a first talk. Nina.
So thank you very much, Fabien, for this nice introduction. So we start with the topic, why is it challenging to image the tricuspid valve? So these are my disclosures. So if you look at the mitral valve and the tricuspid valve, so these valves are completely different. So the mitral valve usually is nicely to image with transesophageal echo. The tricuspid valve is much more complicated, so we know it's a different valve. And why is it more difficult to visualize the tricuspid valve? There are anatomical reasons. The tricuspid valve is located more anteriorly, and this means it's further away from the probe. The insertion of the tricuspid valve is deeper than the mitral valve, and this means the esophagus curves away in this region from the heart, and this makes it more difficult to see the tricuspid valve. In addition, the tricuspid valve leaflets are thinner, and this is also one of the reasons why it's more difficult to assess. Another anatomical reason is that the tricuspid valve is located further to the right side of the TE probe, and you may need additional maneuvers and turn the probe to the right side to get alignment with your tricuspid valve. So the next important point is that we just have limited acoustic windows, as you can nicely shown here, summarized by a slide from Becky Hahn. So we have mid-esophageal, deep esophageal views, transgastric views, but we just have a limited access to the tricuspid valve by TE. And just to give you an impression where the probe is located by using the different imaging acoustic windows. This is from the mid-esophageal to the deep and the deep transgastric, as you can see it here. So in addition, so we don't have only anatomical factors, we also have factors that negatively impact the imaging qualities. So these might, again, anatomic factors, that a lipomatous septum, we can have a very sclerotic aortic valve, which can be annoying. We can have an elongated right atrium, or even a prominent Eustachian valve or a Chiari network. So we also can have implanted occluders or valves that might be in the interictal septum, or we can have a biological or mechanical valve, which can be in aortic position or mitral position, and even pacemaker leads, even for transgastric views, it can be very annoying and cause shadowing. And if you do the procedure, we can also have parts of the delivery system and the device itself, which can cause shadowing. And I just brought a couple of examples. On the left-hand side, you can see a lipomatous septum secundum. This is also a double-layer septum, which causes shadowing above the entire tricuspid valve. In the middle, you see an intra-atrial septal occluder, a PFO occluder, which is implanted, and this causes, again, shadowing, especially in the anterior septal part of the tricuspid valve. And on the right-hand side, you see the shadowing caused by the biological mitral valve. The frame of the biological valve is giving the shadow, again, to the anterior septal part of the tricuspid valve. So a lot of reasons why we have problems to visualize the tricuspid valve properly. And here I would like to thank you for your attention.
So thank you very much, Nina. After the challenges, Felix will show us what could be one of the answers. So what is the technology we have now in Europe for getting better images in patients with difficult anatomical situation? Felix.
Thank you, Fabien. So also a warm welcome from my side. Thank you very much for the invitation to speak here. And I am supposed to give you an overview on 4D ICE technology. This is my potential conflicts of interest, and when preparing this talk, I was asking myself, first ICE imaging, when did it actually start? And on the left, you see in a publication from 1963, single crystal ICE probe actually being able to diagnose an ASD already. And then it was only 20 years later that the TOE was able to do the same. So it's actually quite an early concept to put an ultrasound transducer into the heart directly. But then it was another 40 years actually until this entered clinical practice, and Siemens, hosting the session here, has really been an innovator in the field of ICE, and only last year came out with a beautiful new Accunav volume. ICE catheter that can do 2D and 4D images up to volume rates of 40 volumes per second, and also has pulse waved and continuous waved spectral Doppler, and obviously also color Doppler function. Using 2D ICE for the topic of the session for mitral and tricuspid valve interventions might be intriguing, but actually is not so helpful, especially if you talk TEER. As on the right side, you see the so-called home view. This is what you see when you put an ICE probe into the right atrium. Then you only get that intercommissural view, and you cannot get your grasping view easily. So 4D is a huge step in the right direction. This is a beautiful rendered 3D volume. But now comes a real interesting part, that is multi-planar reconstruction real time. And by this, you can use your ICE probe from a dedicated fixed position in your right atrium. In this example, which was taken from a transcatheter tricuspid valve replacement with the evoke valve that you can see on the right side. Talking indications, when do you think about using ICE? This is a case with TEER after cardioband. In the left image, you can see that the posterior leaflet of the mitral valve is completely shadowed. And then it was actually a 2D ICE probe inserted into the LV retrogradely that beautifully showed the posterior leaflet and how it was inserted in the MitraClip device. So 2D is actually helpful to answer specific questions, but can it really completely go the long way and replace TOE in these procedures? The answer is no. For these, you need 4D ICE, and this is actually a very recent data article still in press, summing up data from 12 patients that underwent mitral TEER without TOE because they couldn't tolerate TOE, these patients, and technical success rate was 100%, imaging done with 4D ICE catheters. And for tricuspid TEER, things go in a similar direction. This is data taken from a recent publication that collected the number of patients that ICE was used in the early CLASP TR feasibility study. And the indication was shadowing, just like Nina said. And interestingly, the ICE catheter, this is taken from a bench model, wasn't too easy to position, but with using a steerable catheter, they did very well, and all these cases also had great technical success. So, summing up, 4D technology in eyes is actually increasing the use case for AV valve interventions. And if you think about it, the TEER intervention may actually be the use case absolutely, as TOE imaging is difficult and access to the right atrium is fairly simple. But of course, this is a work in progress technology, and there's still learning curves for handling and also technology refinements to come. Thank you very much.
Thank you very much, Felix. So please ask your question. We have now a sequence of discussion, and we will be very happy to answer your question. Maybe, Felix, one question for you, and then you can sit down if you want, for the rest of the discussion.
Cool.
Why are we talking about eyes so much now? What is the step, the new thing in technology that make it more easier to use, in particular for the mitral and tricuspid valve?
Yeah, as mentioned, I really think the 4D technology is making the big difference. Imagine 2D, you really have to get the probe around the heart, which is difficult, to get opposing or perpendicular imaging planes. And with 4D and multi-planar reconstruction, you're actually heading in the way probably many images dream of, that you find one dedicated position for your probe, create a 3D volume, and the rest is done electronically.
And Felix, one other question, and maybe other can react as well. Is that something you use in isolation for your cases? So I'm talking mainly about mitral and tricuspid. We will speak about other indication as well later in the session. Are you using it as a complementary technique or as an isolated technique, so doing cases only with eyes? Maybe Stefan first.
I think we're still early in the learning curve. So, of course, we've done thousands of interventions with TOE, which is a regular technique. But we've seen, I think, one of the reasons that eyes is coming more and more of age is that we're doing more and more tricuspid interventions. And I think the benefit there is the highest. And I would say in the beginning, of course, we had two probes simultaneously, and you simply switch between two machines or on one machine between the probes. The more actually familiar we get with a specific intervention, the more you can also move to pure ice situations. And we'll show a case that is purely done with ice. And I think this is not the beginning. Of course, you have to get familiar with it. And I would say the first 5-10 cases, you do TOE and ice. But then you can move more and more over to ice. And the advantage we haven't mentioned so far is that in TAVR, we're doing 99% conscious. In mitral and tricuspid currently, we still do predominantly general anesthesia. So in the future, as the ICE technology moves on, we may be able to do totally conscious procedures like a coronary intervention, because you just have two venous punctures. One is your device, and the second one is a 12 French, or if you use a steerable catheter, Sergio will show this, we use a steerable sheath, which is 14 French, 12 or 14 French, depending on the size of the device, and then you can do your intervention. That's it, and you can put both through the inferior cable vein.
Maybe, Sergio, which kind of indication procedure you will feel comfortable to do with eyes only?
I think that we have to change the point of view, because it's completely different to move from the TOE and eyes, because the TOE is fixed in the esophagus, so you can go in the stomach. The point of view of the eyes is completely different, because you can advance the device on the base of the target that you want to image. For example, for the tricuspid valve, where the TOE has some limitation due to the position of the valve, the distance from the probe, you can overcome all these limitations advancing the probe in the right atrium. You have the mitral, the tricuspid valve in front of you. There is no other structure in the middle, so the quality of the imaging is very, very high. And but at the beginning of your experience, I think you have to use together, because you have to change or to understand the different point of view, because the view from the eyes are not exactly the same view of the TOE. So you have to develop an experience. But I think that I agree completely with Stefan. I think that the next future Many procedures now are done with the general anesthesia will be done in local anesthesia because at the end is a venous puncture or two venous access.
Excellent. Any question from the room before we move to a first case from Stefan?
Already moved to the desk.
Yeah, I see you are already ready. Yes, please.
Hi. Is it possible or feasible to sterilize the ice probe, to reuse it or not?
Sergio.
Not in Italy, and I suppose not in Europe.
Yeah,
I know, maybe in Sweden, I think. I'm not too sure, but I think there is some countries in Europe where it's possible to do it. You can do it maximum 1 or 2 times because after that the quality of the image is deteriorated. But I'm not sure that probably in Sweden. I don't know why, but.
Yeah, no, I think generally it's not the case, but there may be some exception. So you have to use it for every patient again and again. Other question? So Stefan.
There is
it's
a
your
company
turn.
in Berlin. There's a company in Berlin that remodels, but the quality deteriorates over time. So we have done second use and third use cases. So there's a professional company, and it's allowed, but it's not recommended if you do a very important case. The crystal or the device will deteriorate over time. So we usually use it only one time only. So I come now to one of the images or the cases actually that we can do in order to use this technique. And this will be a transcatheter tricuspid valve procedure, a TEER procedure that we did in our institution. Actually, also the EVOC case was done already in 2019 with the first 4D ICE probe actually at our institution in October and November 2019. So we've seen this slide already, and I just want to use it in order to help everybody who is not familiar with the ice situation, but also to make one important point. And this is unlike two-dimensional ice, four-dimensional ice has a much shorter learning curve. And this is because you keep landmarks in your image. So you're able with also MPR, which is multiplanar reconstruction that you may use in CT images, you're able to do this live over minutes, half an hour, 1.5 hour, to actually depict your interventional scene and to make a lot of different views possible. So just to give you the alignment, you see this was the home view that Felix described already. And here you see one of the enemies that we have, which is a pacemaker. And in real-world registries of tricuspid interventions, we have approximately 20 to 30% of all patients having pacemakers, which give us shadows. Also ICE probes, etc., ICE intracardiac probes, and we also may have ICD probes in these settings. So you see that we have an excellent image, and also look at the frame rate, and we already discussed this. Technically, this is 40 frames per second with a catheter that is only 11, 12 French large. You can see the aorta to the right-hand side, the anterior leaflet, the posterior leaflet, and you see that in the commissure is actually a pacemaker probe. If we now add color, you can appreciate that we have a severe tricuspid regurgitation, and you can also see that we're still running with color Doppler these images with 22 frames per second, which is of course a two-dimensional image made out of a three-dimensional probe, and this is along the catheter, so it's of course the best situation for this EchoNav volume rendering. The next step is then to use multiplanar reconstruction that you can see here. So we can appreciate the aorta still in the image, and now we're able actually to rotate to any anatomically driven position that we may like. And you will also see that we're able, unlike biplane imaging by TOE, always to go along with the catheter and with the arms of the TEER device. So this is an additional use. And of course, we're here not in the leaflet level of the leaflet cooptation, but we see this as a three-dimensional image, but we're in the hinge point level, so in the annulus of the tricuspid valve. Moving forward, we can use the same plane and add color to it. You can see that we can shift the color frame here within the image to any given position, and that we're still, in this early technique, we're working here with 11 volumes now per second in order to align to any given plane and to drive and to plan the procedure in this specific patient. Now we're entering via fluoroscopy and also ICE catheter. We can retract the ICE, we can retroangulate the ICE in order to see also bicaval views. And here we're entering down with a device into the level of the tricuspid valve. And you can see just by aligning the different situations that we counterclock according to the device arm. We're also clocking the situation according to the extension of the device, and we can see its position three-dimensionally in the tricuspid annulus and including the motion of the leaflets. Now comes the testing of the two clasping or grasping plates here. This can be either a Pascal or, in this case, a tri-clip, so both systems work with it. And we have the great advantage that you can, of course, change the position of the device easily in the liquid volume of the right atrium. So in order to avoid shadows, it's far easier that we can move anterior or posterior or further cranial in order to overcome the shaft of the implant device in order to get excellent images on the device itself. And I think you can appreciate that we see these movements easily in this setting. So now comes the mobility down, and again you see the leaflet motion. You can see that we can depict easily the leaflets and also the position of the leaflets into the center of the TEER device that we used here. And at the lower level now you see the short axis position, which gives you the rotation, and this corresponds to a transgastric view that we don't need anymore in this situation. So everything is done out of a right atrial position of an ICE probe, so you avoid a certain number of steps, which can also cause bleeding, because typically these patients are congested with tricuspid valve regurgitation. So very often, especially in centers that start and you move into the transgastric and out, you forget to unband or whatever you do, you can cause gastrointestinal bleeding. And this is totally avoided with this technique. You just add a second venous puncture to the groin on the contralateral side. Now we are grasping. We can see now the valve changes. You can see that the anterior septal bridge is now achieved on the three-dimensional volume. So this is the first device implant, and you will see a second one, and then the whole procedure is done. This is a second. You see now on the left image, you see anterior to the aorta, the first device. You now see just next to it, adjacent to it, with 3 millimeter distance, a second device being implanted, and you can see that now in the three-dimensional image, the leaflets, the residual leaflets of the tricuspid valves fully coapt, and we have no gap anymore, and this can be controlled simultaneously with the three different views. So we have a transesophageal inflow view on the left upper side, we get the corresponding four-chamber view on the right-hand side, and we get the transgastric view down simultaneously with a four-dimensional image, and it's the same heartbeat that we're looking here, and you see it's multiple heartbeats. So this is not triggered, it's live imaging that we attain throughout the procedure. Now we can control the situation, which is a trace to mild residual regurgitation, and we can also do pulsed wave or continuous wave Dopplers in order to control the gradient across the valve, and this is the complete analysis, which doesn't need to change to a TOE probe. So my take-home messages after this short showcase is that 4D ICE offers a perfect echo windows to the tricuspid valve intervention. Orientation is much simplified in comparison to 2D ICE with maintaining the landmarks throughout the intervention. Volume frame rates may differ between 10 and 22 up to 40 frames per second, not volumes per second. The volumes are typically lower. And structural heart interventions have an addition to the imaging toolbox with this device. Thank you very much for your kind attention.
So thank you very much, Stefan. That's a very nice demonstration. I think edge-to-edge is probably one of the most challenging procedure with eyes, because you really need to see both leaflet at the same time. And that's why the second plane or 3D, as you nicely demonstrated, is extremely important. I just want to come back to you, Nina, and on the indication for this. So we have seen, Stefan has mentioned pacemaker. What are the clinical scenarios, on maybe first on the mitral and then on the tricuspid, where you really consider ICE either as a complementary technique or to guide your procedure?
I think if you look at the mitral valve, it's most likely, in many of the cases, you can get really good images with TE, but we have a couple of patients who are not able to tolerate a TOE probe. So for these patients, it's a really good option where we could use ICE. On the tricuspid, it's much more beneficial, I think, if you have an ICE probe available. And if I think the anatomical most challenging thing is shadowing coming from any structure of the right atrium. And this is very frequent. If you just think about the lipomatous septum secundum, this is a very, very frequent finding, especially in elderly patients. So this is very helpful. And if you think about the kind of procedures, so this is especially, so in my experience, a cardioband procedure, because it's getting really difficult if you're coming to the lateral side of the tricuspid valve and the transition zone from the lateral to the posterior side. So in this space, it's extremely helpful. And if you do a TEER procedure, it's even more helpful if you have to address the posterior septal commissure compared to the anteroseptal, if you have a modality which allows you, because a lot of shadowing is kind of going on there, it allows you a really nice visualization of the commissures.
Any question from the floor?
Here's a good one.
Yes.
I'm happy to read it out. Here someone is asking, in the future, who will be the leading and in charge of ICE during the procedures, the echocardiographer or the interventional cardiologist? Maybe it's really an interesting question, and who should answer this? Maybe, Sergio, what is your take on that?
It's getting political, Sergio.
Yeah, that's why we have Italians on the table, you know.
So my personal opinion is that we have to move toward the new professional profile of the imager, that he will be or she will be an interventional imager that cooperate at the table with the interventional cardiologist, because for the imager it is extremely familiar to manage the probe and to obtain excellent imaging. Probably of course we have to change the cath lab organization and the role of the different operators. This is my personal opinion.
There's another question coming up, and this is the question: how different is it from 3D TEE? I think positioning is one thing, but do you have additional things to add?
I think it's not so different from TOE. Actually, we'll see that more and more of the image processing is basically the same between ICE and TOE probes. I totally agree that the interaction between the imager and the interventionalist has to become closer, and we also rotate in our lab between the imaging and the intervention position. So typically, if you want to become an interventionalist in AV valves, you have to be first an imager, and then you proceed to the table. So I think this helps to add to this in the future.
Sergio, I know you have a lot of experience. So what do you think about the learning curve? If I want to introduce it into my cath lab daily cath lab practice, how long do I take to really be confident to use a ICE probe?
It depends on your background. If you came from the ICE experience, and it depends on the kind of procedure. If you have a good experience with the 2D ICE, probably 4 or 5 cases for tricuspid is enough. I'm not clear idea for the mitral, because the quality of the TOE imaging is very, very nice, so I'm not sure that it will be replaced, the TOE, for the mitral.
That's a good transition to your talk, Fabia. So we'll have the mitral valve now in the focus, and you will give us a nice case presentation where you used ICE in a mitral case.
Yeah, I just wanted to show you this as well, as a follow-up to the case of Stefan. You can do, of course, also procedure on the mitral with that, and that's an edge-to-edge procedure, and then we will move to another type of procedure with cardioband. So this woman is a very high-risk patient, actually. She's not so elderly, but she has, as you can see, a multiple pre-operation, and the problem, which was a very uncommon one, she had a compression of the abdominal aorta with concern about perforating the esophagus and the aorta, and having a complication from TOE. So that's why actually we decided to go for a nice guided procedure only. So in isolation, we had some TTE images as well during the procedure, but the goal was really to treat mitral valve here on using ICE only. So you see severe mitral regurgitation, you see the value of the right heart catheterization as well, and that's a correlation of the intraprocedural imaging between TTE done on the table and ICE. So you can see that we are actually able to see the pathology quite nicely and to prepare the procedure. And then of course you will need to do the transeptal puncture from ICE guided only, which can be challenging. So you place actually the ICE catheter into the atrium, in the right atrium, and you look at the septum, so with a position looking up towards the septum, and then you do the puncture, and you are able, as you see, to see the needle quite well. It's just coming from the other side. And finally, you dilate the septum, because you will need, and that's a particularity of this procedure, to introduce the ICE catheter into the left atrium. That's challenging, and you see the technique here. You mark the entry with a catheter, with a wire, and you follow then with your catheter. You have to find the hole to be able to go on the left side. And then very similarly, I don't go into details, you have seen this very nicely with Stefan. We were able to implant one clip using, of course, multi-planar reconstruction, not so much 3D in that case, and then we could implant a second one with a good result. You see the fluoroscopic images, the corresponding one with the catheter in position, and finally what we did in that case, because there was a lot of manipulation, and I think you need to be prepared to that, we finally close the EST, which you can do also very elegantly using ICE. So it's providing really the imaging you need in any situation. So that was an example of an exclusive use of ICE in patients with TE contraindication. Then, of course, multiplanar reconstruction is very, very important. And we mentioned this regarding the learning curve. The training is extremely important, both of the echo and the interventional cardiologist. Thank you very much for your attention.
Fantastic, Fabian. I think we really could realize it's possible. So there's a question popping up if ICE or 340 ICE will be able to replace TE during transcatheter tricuspid valve replacement. So Stefan, you showed one of these images in your talk. Can you comment on that?
Well, I think there are different types of devices, and I think for those who use mainly hinge point annular support with radial support of the device, which is a one-time implantation, it is perhaps less useful. If you have a device that uses anchors to the leaflets, like the VOC valve, for instance, it is more likely to be useful because you can check the individual positions of the leaflets versus the device. So I think the more you go to the tricuspid, the better. I think cardioband may be a very good indication, but also some other structural interventions are prone to be possibly ICE-guided in the future. Yeah. And the one I would like to mention is perhaps even chordal replacement, where we try to enter into the papillary muscles. So this could also be seen if you have a ventricular orientation with your ICE probe. So this will have to be seen. So perhaps Sergio can.
Yes, probably from the right ventricle, with the correct orientation of the volume of acquisition toward the apex of the left ventricle, with the addition of a long sheet steerable catheter, probably I think it will be possible, because the visualization should be extremely detailed.
So Stefan, you mentioned cardioband, and maybe we can look at your case, Sergio, on cardioband. You have one?
I have some slides.
Yes.
Yes.
Yeah.
I think so.
Yeah, just quickly to
You
use
have
the
question,
time
yeah.
properly, there's another question, interesting. What kind of anesthesia you use for these cases? I think that really touches the point that with TOE you typically do need anesthesia and that ICE can rule it out, right? So
Yeah, I agree.
Okay,
So-
I start from the slides that you showed before. Cardioband is a very complex procedure because it requires to anchor 15, 17 anchors along the annulus in a precise position, but not only in a precise position, but also with a precise orientation. So we need a clear visualization of the anchors, of the leaflets, of the hinge point. Usually we start from this view to approach the first anchors toward the aortic valve, and then we move in a clockwise direction from the anteroseptal to the posteroseptal commissure. To get a good quality of imaging, we have to use the 4D ICE in a dedicated manner. With the support of a long sheet steerable catheter, we need to advance the probe inside the valve, and for a correct visualization of the anteroseptal portion of the annulus, the best solution is to place the probe in posteroseptal commissure and reorient the volume acquisition toward the anteroseptal. You acquire and you have a good visualization of this portion. Then you move anterior all the system, and keeping the long sheet in position, you rotate 180 degrees the probe, and you have an excellent visualization of the posteroseptal and lateral view, and the septal is well visualized moving in lateral position between the anterior posterior commissure, and usually you have a good visualization of the annulus. You don't need to move from transgastric to the transesophageal position, and the main advantage is that to place the probe, you acquire the volume, and then electronically you scan all the annulus. And at the end of the procedure, you see the detail of the annulus. You see clearly the position of and the thread of the anchors. The detail is very, very, very good. And okay, this is the detail of the stability test. Is clearly visible the movement of the catheter during the push and pull, the hinge point, the leaflet, and clearly the position of the anchors according to the annulus and then the leaflet. And at the end of the procedure, when you put in tension all the system, you go back in the right atrium. You have in front of you the tricuspid valve, and during the tension you can evaluate the color Doppler, the distance from the lateral to the septum distance, and the gradient in terms of millimeter of mercury. And our experience is after a short period of learning curve, all the procedure can be done completely with the intracardiac 4D. We had at the beginning the excellent experience with the 2D, but to get the correct orientation of the echo beam is complex because it's single planar view, so it's extremely complicated. Thank you.
So thank you very much, Sergio. Very impressive, and that's the next level. So that's not only having the ICE probe in the atrium, that's orienting your ICE probe depending on what you want to see. And for this, you need an additional sheath. So you have demonstrated this very nicely. I think very challenging. Maybe one question for Felix. In terms of resolution of this device, we need to see different things, the leaflet, sometimes the annulus, we see also differences. You show, Sergio, 2D images, and then you switch to the reconstruction, the multiplanar reconstruction. What can we say, Felix, in terms of resolution? Are we there, or do we need to improve this?
Yeah, very important question, Fabien. Thank you. I think let everybody else judge. We had TEER on the mitral, TEER on the tricuspid, and the cardioband, and both of you guys had beautiful results for TEER without using a TOE probe. So I think spatial resolution is actually quite decent. Of course, this is a scientific session, and we're showing the very good cases, and there's cases with very long atria and complex morphologies, hugely dilated annuli, where the world is more complex. And then I would say yes, there is room for improvement to get us bigger fields of view and even more crystals for a higher volume rate. So this is a very decent start, but to really rule out TOE, we need some technical advancements, is my opinion.
So the chat is active, so we have a couple of questions here, and one would be, do you see any advantages of fusing eyes and fluor images like we have it with TE and fluoroscopy, fusion overlay?
I think the difference to TOE is that you cannot align so much with the orientation of the TOE probe, which is larger, which in case of some companies has certain drills in order to precisely see the rotation and also the banding of the device. So if you want to do this, it would be another technique, and this is image or pattern recognition. So you have to use a valve recognition program in order to align and overlay these situations. You cannot do it so much by the rotation or by the angulation of this very small ICE probe. You've seen it in the fluoro images. Some of those were seen. So there is a different technique behind that, and this will need some time. But I agree that within a given structure that you can derive, for instance, from a 3D CT, you could also test the view where you are with the ICE probe.
And a question from Regina Riberas here. You're coming from high volume centers. How do you decide if you want to use ICE in a TEER case or TOE, or how to decide to use both options? So that's maybe also for you, Fabien, high volume centers?
Yeah, it depends. No, I think the driver for me actually to introduce ICE is some kind of frustration when you are in very challenging situation, doing edge-to-edge or doing cardioband, and you just don't have sufficient quality at some point of the procedure. It could be variable. It can come during the procedure, and you cannot finish the procedure in some way. So that was really the driver. And I think that's a situation you start because our images are better and better, and that's a situation you start to see when you do a lot of cases and you accept also challenging cases and so on. And the other one is, it's important to have a solution for the patient with this characteristic. So it's really, it's driven by the need of treating patients that are referred to you with complex situation where you really want to offer a solution. Stefan, do you see?
I totally agree. I think it also depends on the anatomy. I think the more you're left-sided, the more you're TAVR or mitral, the more you will use TOE, to be honest. The reason why this is used differentially is that you want to overcome the situation you have no image, like on TOE. In the past, we said we moved to TTE images, but this is very inferior. Now we do them all with TOE, but sometimes you don't get the crispiness. You have a technical valve, you have two technical valves, like in our case with the EVOC. This patient had two technical valves surgically in aortic and mitral position, and then at a certain point you're stuck because you don't get any transesophageal images anymore. You only have transgastric, and then you need an addition. And I think the more you move tricuspid, the more you go ICE in the future, and it's just the beginning of the journey. I wouldn't say we're at the end. It's not routine use yet, but it's, I think, a very important situation for something like 10-20% of the tricuspid cases, and I would say less of the mitral, and perhaps LAA. That would also be an indication to use ICE situations and to move away from general anesthesia, which is also different in different countries of Europe.
This is a good point, Stefan. Here's another question, maybe somehow related to that. So how far can the viewing distance of the 4D eyes be? And if you think of a left atrial appendage occlusion procedure, for example, would it be possible to guide it appropriately from the right atrium, where you have a pretty far distance to the left atrial appendage? Sergio?
The quality of intracardiac echocardiography from the right side of the heart for the LAA are not very good. At the beginning of the story of the use of the eyes for LAA closure procedure, we advanced the probe in different position. The best solution was the coronary sinus, but the quality of the imaging is excellent. The main problem is to engage the coronary sinus is complex and is potentially dangerous, and the only solution is to advance the probe through the fossa ovalis in the left atrium and to advance the probe at the ostium of the left superior pulmonary vein. You have a perfect visualization on the LAA, and you acquire the volume, and using multiplannar reconstruction, you can do exactly what you do with the TOE or evaluate the landing zone exactly what you do with the CT scan.
Yeah, thank you very much. Thank you very much, Sergio. And thank you to everybody for reacting so much. We had a lot of questions in the chat. We need to conclude slowly the session, but I would like to ask you the last question. We asked before who has used eyes in the practice, and now we would like to ask you whether we convince you to use it. So who will go out here and buy an eyes catheter? So hand up. Oh my! Oh, you can vote as well. You consider for use? Oh. Oh, it's changing all the time.
Oh, it's changing.
Huh?
Yeah, see.
But did we convince you or not? Who is convinced? I am convinced. Oh, they
see, we're at 60%. This is pretty good,
there are two
actually,
people more than before. Okay. So that's perfect. Thank you very much. No, I hope you learn about training, very important point.
Yeah.
You learn about different indication. We have seen a lot of different indication, a big spectrum. So I think a large potential for this technology in the future. Thank you very much. Have a good evening in Paris.